Clinical Reasoning in Internal Medicine. Case 2. A 37-year-old executive returns to your office for follow-up of recurrent upper abdominal pain. He initially presented 6 weeks ago, complaining of an increase in frequency and severity of burning epigastric pain, which he has experienced occasionally for more than 2 years. Now the pain occurs 3 or 4 times per week, usually when he has an empty stomach, and it often awakens him at night. The pain usually is relieved within minutes by food or over-the-counter antacids, but then recurs within 2 to 3 hours. He admitted that stress at work had recently increased and that because of long working hours, he was drinking more caffeine and eating a lot of takeout foods. His medical history and review of symptoms were otherwise unremarkable, and, other than the antacids, he takes no medications. His physical examination was normal, including stool guaiac that was negative for occult blood. You advised a change in diet and started him on an H2 blocker. His symptoms resolved completely with the diet changes and daily use of the medication. Results of laboratory tests performed at his first visit show no anemia, but his serum Helicobacter pylori antibody test was positive. What is the most likely diagnosis? What is the next step in therapy? Let's see the key points of this scenario. A 37-year-old man presents with complaints of chronic and recurrent upper abdominal pain with characteristics suggestive of duodenal ulcer. The pain is burning, occurs when the stomach is empty, and is relieved within minutes by food or antacids. He does not have evidence of gastrointestinal bleeding or anemia. He does not take non-steroidal anti-inflammatory drugs, which might cause ulcer formation, but he does have serologic evidence of H. pylori infection. Most likely diagnosis: peptic ulcer disease, PUD. Next step in therapy: antibiotic therapy for H. pylori infection. Note the following for this patient. 1. Know how to differentiate common causes of abdominal pain by historical clues. 2. Recognize clinical features of duodenal ulcer, gastric ulcer, and features that increase concern for gastric cancer. 3. Understand the role of H. pylori infection and use of non-steroidal anti-inflammatory drugs, NSAIDs, in the etiology of PUD. 4. Understand the use and interpretation of tests for H. pylori. Considerations: in this patient, the symptoms are suggestive of duodenal ulcer. He does not have alarm symptoms, such as weight loss, bleeding, or anemia, and his young age and chronicity of symptoms make gastric malignancy an unlikely cause for his symptoms. Helicobacter pylori commonly is associated with PUD and requires treatment for cure of the ulcer and prevention of recurrence. This patient's symptoms are also consistent with non-ulcer dyspepsia.